Good afternoon, everybody. We will be just getting started in just a minute. So welcome to my bedroom. And this is how you guys might be doing your assessments. So I figured it was quite real. As everybody's logging in here, would love, I don't know if we have the chat option on this since it is webinar setting and not a meeting. No, we do. So say hi, introduce yourself. Who are you? Where do you live? And what do you do? Are you a personal trainer, group fitness instructor, aerobics, yoga, whatever? Let's all get to know each other. And I'm not going to be able to check the chat box while we're doing this because obviously I'm going to be doing the assessment. Also rocking the new CETI Cancer Exercise Specialist tank top. So if you haven't gotten yours, we have these and t-shirts and sweatshirts. Super excited. Hey Tracy, I'm home in Portland. Hit me up later. We'd love to touch base with you. Hi Sandy. Yay, 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 yay. Welcome everybody. I'm just going to wait till some more people get on. Let's just give it another minute and then we will get rocking. Hey, Nikki, welcome. Anthea, Abby, yay. So good to see all of you guys here. So when you come to Portland, you can visit and stay in my log cabin bedroom. This is what makes me happy on the rainy days. Hi, Eduardo. Welcome. We have about 2/3 of the people who are registered on. So let me just give it a couple more seconds and let me kind of tee this up. So we have full view and I'm going to be manipulating the computer a bit while we're doing this, guys, just like you're going to have to. Welcome, Michael. This is real life, guys. This is COVID 101 virtual assessments. This is not going to be perfect and it's not going to be perfect for you either. So I want to convey that to you. I'm going to do this as real as possible. So I'm going to go ahead and get started, and we're going to begin today with a postural assessment. So I want you guys to think about communicating with your clients, and even those of you who do any type of group exercise, so, you know, Zoom or in person. This is a great segue to get people into your classes in the safest and the most personalized way possible. I think there always needs to be some sort of an assessment. We can't just throw every cancer patient into a group class and expect it to be safe or effective. But if we can do these few tests that I'm going to show you, the postural assessment, the goniometer, modified Thomas test, at least then we have something to go on, and we can either group people together and say, okay, you know, everybody who has XYZ symptoms or side effects, or this age group or this gender, whatever the case is, we can work to form these small groups or, you know, maybe down the road when you feel more comfortable, larger groups. And one of the most amazing ways to do a group format is you can get online and you can buy the little rubber bracelets and get red, orange, yellow, green, blue, purple. And each one is connected with something like limited flexion, limited abduction, upper cross syndrome, excessive lordosis, upper extremity lymphedema, lower extremity lymphedema, so that when you're conducting a class, you can simply say, hey, if you have a red wristband on, and you know that means limited flexion, then if somebody is doing a warrior one and they have a red wristband on, we can suggest that they do it fluidly as opposed to holding that position, which with that isometric contraction is going to build strength. And remember that we always want to have them in that normal range for range of motion. So if you guys are not through the Cancer Exercise Specialist program, this will all make more sense once you've gone through all the modules. But as we do the postural assessment today, remember, before we even incorporate strength training, we're going to assess shoulder range of motion, And that is going to trump everything else. So we do our cardiovascular warm-up, then perhaps we're incorporating our lymphatic drainage exercises for those that are at risk. And then next, we go into improving range of motion in the planes of motion that are limited. Following that, we can start to look at our postural assessment and take, you know, those muscles that are too tight and those muscles that are weaker and come up with the strength training program or that part of the component. And then finish off, of course, with, you know, our cool down and so on and so forth. So this is not about exercise programming, so I don't want to go too far into that today. This is simply about the assessment procedures. So I am going to welcome my dear husband, Jeff, over here, and I'm going to mess around with the camera a little bit, you know, so we can see his feet, we can see his upper body. So Jeff, we're going to kind of center you over here. And first, let me explain how you're going to do this. So you're talking to your client. You can pretend you're training Jeff and you would be, you know, barking commands like I'm going to. And you want to make sure your client takes their shoes off, that they are in socks or barefoot, so that if they do have orthotics or a lift in their shoe, that it is not affecting their stance. We want to encourage them to stand relaxed, however that is. We don't want them to try and stand like, you know, they're in the army and try and have perfect posture. So the first thing I'm going to say to Jeff, and let me kind of get out of the way here. We'll start off with kind of most of him. I'm going to ask him to march in place with his eyes closed. Now, even before we do anything, I'm already looking at his legs. Keep marching, Jeff. Okay, and then just stop for me. Okay, so what we're going to do right now, guys, we are going to start at the bottom. Now, you can start at the top or the bottom. Different people have a different way to do it, but see what he just did? That's not okay. So now we have to start all over again, Jeff. March in place, and trust me, you're going to go through this with your clients as well. Okay, so go ahead and relax, stop, and don't move. Now, as far as lighting and everything goes, guys, it's not going to be perfect. So you want to try and have your clients adjust the lighting as much as possible. I've got all the windows, you know, open, the shades pulled back. Not going to be perfect. So we're going to do the best we can with what we have. Now, if you have never done a postural assessment before, look, you're going to have a recording to this. You can watch it over and over again. It's certainly going to be easier when you're in person, no doubt. But we can still gather a lot of information virtually. So right now, of course, I'm here, you're watching me do it. In real life, you're just going to be talking to your client. So basically, this is all you're going to see on your end. So what I'd like you to do, and Jeff, you're just going to have to hold your position there. Let's start with his feet, guys. And the cool thing is I can actually move the computer here while we're doing this. Okay, so we can actually hone in right there. Hopefully that's not blurry. And I want you guys to look at his foot positioning. So what do we see here? Now, the goal, of course, is that both feet are going straight forward. So what I immediately see is this foot turned outward, okay? This one ever so slightly, but this one is probably out maybe 20 degrees. Hopefully you guys can see this okay. Try a couple different angles here. And then I also want to look to see if he's supinating, where he's rolling outward. And that puts a lot of stress on the little toe and the lateral side of the foot, where with somebody who's pronating and it's rolling inward, there's a lot of stress. Whoops. Hold on here. Where'd you all go? Sorry about that. I don't know why a call is coming through when my phone is on airplane mode. But anyway, as I was saying, when it pronates, you're putting a lot of stress. And Jeff actually has kind of a bunion here. And for a lot of people, that can result in fractures. And also what happens when the foot is rolling out in supination is you often have what we're going to call bow legs. Now you can't see his knees yet. I want you to focus right here, but hopefully everybody sees what's going on. And when you guys look in your handbooks, you're going to be able to go to the assessment sheet and see where it says, I'm going to move this up a little, guys. See where it says, here is the postural deviation, and here are the muscles that are probably tight, here are the muscles that are probably weak, and how to correct them. So it's really going to be a no-brainer once you get into your handbooks, and then you can even go to the next pages and it will show you sample exercises. So the next thing I want you guys to focus on, and by all means, let me know, I'll try and check the chat box periodically if you're not following me. I want you to look at his knees here. So when we look at the patella, okay, do you see a patella that is laterally rotated, which is moving outward, or do you perhaps see a patella that is medially rotated? And keep in mind that a lot of the things that we see on the postural assessment, we are going to reaffirm with the modified Thomas test and the squat test, because we get different angles and we get to see things that are dynamic as opposed to static, like in this postural assessment. All right, so when I am looking, and again, the lighting doesn't help here, but what I see is laterally rotated patella. So Barb, I see you writing, I see something about the left knee, but I really can see how the patella are going out to the side. So I'm going to try and use very lay person terms here, guys. And that makes perfect sense when you've got somebody whose feet are supinating, because everything is going out laterally. Now, this can result in all kinds of pain throughout the body. It can be ankle pain, it can be knee pain, hip pain, and it really depends on where the defect, if you will, originates. And we don't know this until we look at the entire body, all right? So next thing we want to do, and this is where you're going to have to describe to your client how to do this. In person, I can come over here and I can palpate and I can find the iliac crest, and I can find the anterior and the posterior, you know, iliac crest and iliac spine and all of those things. So I have to describe it to him. So Jeff, I want you to find the top of your hip bones, if you will, and I want you to put, yeah, there you go. So I want to be able to see where his fingers are. Let me move this up a little and see if we can get some better lighting for you guys. Okay, how's that? Does that look okay? So Jeff, yeah, if you can use your second finger, the thumbs are not big enough. All right, so guys, tell me, do his fingers look level? Okay, I'm going into the chat box here while he is holding his fingers there. Okay, so Vanya, what do you see? What do you see? Which side looks elevated? Okay, so now are you talking left, like looking at him, which is actually his right? Because I see this side elevated. So that, yeah, exactly. All right, guys. So that could indicate that he may have a leg length discrepancy, that leg may actually be longer, but we don't know that yet. He could also have a tight QL on that side. All right, so this is just the beginning. Now, what I'm gonna have Jeff do is he's gonna have to turn sideways, and we're gonna have him march in place again. So I'm trying to be as hands-off as possible, because this is what you're gonna be dealing with when you guys are doing this at home. All right, here we go. Okay, go ahead and stop, Jeff. All right, so I'm gonna instruct you, Jeff, to find the bony mass right there, the front of your hip bone, but you're gonna need two hands. So then you're also gonna need to find the posterior. So the anterior superior iliac spine and the posterior superior iliac spine. Now, as you can see, he's blocking our view. So we're gonna have to say, hey, Jeff, I need you to move this hand out of the way so I can see. Take your thumb and put it in that spot, and take your thumb and put it here. So needless to say, I'm cheating because I'm here in person. I don't know if he actually has the right spot, but we're just gonna do the best we can. So guys, take a look at this, take a look at him, and can you tell whether or not he has an anterior tilt. Yes, Barb, you're getting so good at this, Barb. Awesome. So he has a very slight anterior tilt, which means that he's tilted like a teapot, okay? His anterior is a little bit lower than the posterior. What we want is level, right? Okay, so we got that. So we're marking down so far that his feet supinate, that his left foot rotates or everts, that his knees are laterally rotated. We are also notating that there is a slight elevation in his right hip and that he has a slight anterior tilt. Now I'm going to go back to his feet again just to show you something. So if you will, Jeff, this time face the back wall. Okay, we're going back down here. Okay, go ahead and march in place again. And then just stop whenever you're ready. Okay, and from here, we can get the view of his Achilles tendons. We have kind of a different angle where we can see whether or not the feet are going out, because if they were going straight forward, you probably wouldn't see them. Notice how much more you see the one on the right than you do on the left. The other thing we get to look at here is looking for the back of the knee, a couple things, okay? One is this line here on each leg, or that crease, and is one side higher than the other? So see if you can hone in on that. The other thing is whether or not they are hyperextended. Okay, so Nikki, what do you see? Which side appears higher to you? And in the meantime, yes, well, it's actually, are you seeing this one? Because that one looks higher to me. Okay, perfect. Then also there's somewhat of an outward bulge here. I don't know if you can tell that through the computer, but that can indicate tight quads, because when the tights are quad, it's gonna stretch posteriorly even more. And so we're starting to get a feel for what do we need to do, which muscles do we need to stretch, which muscles do we need to strengthen, not to oversimplify it, but to give you some idea kind of where we're going from here. And now while he's here, let's get a back view. So Jeff, so if you can go back and if you can find the top of your hips, which is your iliac crest, again, like you did where you were poking. Okay, so we still see that there's a little bit of asymmetry there. All right, perfect. So now I'm gonna back this up a little bit so we can see. Yeah, Ginny, do you want me to move it in closer? Okay, Janelle, I see your question. If you can put it in the chat box, because I don't know if I can like unmute you or anything, but do you see that okay? Move it up, how's that? Okay, Jeff, go ahead and do your fingers again. Exactly. So I got you covered, Ginny. All right, so I'm putting this back on my stand so I'm not wobbly. And now I'm gonna turn Jeff back around. So Jeff, let's march in place. And now let's focus on his upper body. So I want my client to stand with their arms relaxed at their sides and not trying to stand straight. So what do you guys see right now? What do you see? Let's look at his hands. Let's look at his shoulders. Hit me up in the chat box so I can see your thoughts on this. Okay, right shoulder lower, right hand. Hold on, I gotta open up this chat box here. Da, da, da. Right hand lower. Okay, so again, remember, this is his left side. So just think backwards like you're teaching a group exercise class. So yes, I definitely see, in this case, his left hand being lower, okay? And look at everything. Look at his fingers, look at his shoulders, look at where his head is aligned. Rounded shoulders, absolutely spot on, Jenny. And Barb, hands are facing almost backwards. So the only way it could be a little bit worse is if they were completely facing backward. So that is one of the things you guys can hone in on immediately. Yes, tight chest. Left arm closer to the body. I see that as well, Eduardo. Absolutely. So you guys are getting some good visuals here. I definitely see how this arm is further out here. And so, of course, what happens if somebody has tight pecs and Jeff works at a computer all day long, you've got the forward head and then tight pecs, which, of course, is overstretching posteriorly. So he probably needs to do what? Just generally speaking with the round shoulder syndrome. Okay, Nikki, I'm coming back to you in a second. Okay, well now Eduardo's saying the same thing. So head is slightly tilted. So you guys, nobody can see your responses. If you can go down to the bottom and it should say all panelists and attendees, so everybody can see your answers, that would be awesome. So if his head is slightly tilted to the left, what might that be an indication of? Barb says she still likes you, Jeff. Tight trap, absolutely. That could certainly be a possibility. Also, now he's not left-handed, but a lot of it can have to do with, you know, which hand somebody's predominantly typing with, what side they carry, their briefcase, their suitcase, their pocketbook, their purse, whatever. Tight sternocleidoid mastoid, absolutely. And Eduardo, when we get into people who've had radical neck dissections and they don't have a sternocleidoid mastoid, what happens is you've got the scalenes, the levators, the upper traps that all take over in synergistic dominance. So yeah, spot on, Portia. You know, maybe he's doing this, or maybe he holds his phone there. I'm going to have to talk to him about this and change these habits. Okay. So what else can we see from the front? Anything? So we know that the right shoulder is slightly elevated. His head is slightly tilted to the left. And he definitely, I can even see, you guys, do you see his entire body rotating this way? See how this hand is further back? Now, this is a stupid question. Good job, Eduardo. You guys can't, the chat box isn't like in front of him when you're looking at this, is it? I don't know what your view looks like, but I have to, if I keep it open, then it's right in front of him. Let me move this out of the way. Okay, perfect. As you all know, anybody who knows me knows that I am not good at technology, but I'm really good at postural assessment. Nikki, not in a good place. He's trying to keep from turning. Okay, so if he is rotating this way, I mean, yeah, maybe he's looking to see who's coming in the door, but what else could be going on? Does that mean things are shortened here and perhaps he's overstretched in this piriformis? Or could it be that this piriformis is tight, which is rotating him, pulling him this direction? What are you guys' thoughts on that? Sorry, you keep getting like part of me. I'm trying to read the screen here. What do y'all think? Let's talk about that rotation of his hips. And that may be why his right arm looks like it is further away from the body, but it's also all rotating. So left side tightness could absolutely be. And we don't have to have all of the answers right now. We're going to figure this out as we go along. Okay, let's also look at his ears. Can you guys see? And you know, I don't know if there's enough light. not the top of your ears, but your earlobes, bottom of your earlobes. I'm in trouble later for making him do this. Definitely too much sitting. Absolutely. Who wants to get on a plane and come train my husband? You can choose Oregon, New Mexico, or Colorado. Okay, so you see that the level of the earlobes varies slightly as well. So I am now going to go back to the side view. Colorado, all right, Anthea, you got it. Go ahead and turn sideways, Jeff, for me. And I'm going to find something. I need a pen or something. Here we go. We're going to use a knitting needle. You didn't know that I knit, did you? Okay, so what I am going to do, this could be a pen, this could be a pencil, a crocheting needle, hook, whatever. I am going to take this. Now, obviously you can't do this when you're doing this virtually, but I just want you guys to see what I'm showing you. So if you imagine a line going straight down from his earlobe, it should line up back here. So can you see how forward his head is? And you can also look and see kind of an excessive curve there in his cervical spine. Do you guys see that? Pull that man up from his crown. That's from Barbara. Barb, you may not be invited back to Colorado if you keep it up. Okay, so that just reinforces this whole upper cross syndrome. So I tell Jeff all the time, I'm like, if you don't stand up straight, you're gonna look like one of these little old men someday. So we know that we have to work to bring his shoulders back and bring his head back in alignment. And that when he does this, it's going to change his hand position completely. And this is the thing. So many fitness professionals are out there, you know, just randomly giving people workouts. How do you do that without looking at somebody's posture? How can you not do at least some form of a postural assessment and call it individual? And then by the same token, what if you're teaching a group class and you have everybody doing the same thing, but they all have different needs? Then, you know, people potentially are going to exacerbate these imbalances. Okay, so from there, now you can do a more comprehensive postural assessment, but the reality is there's only so much that we're going to be able to look at, you know, virtually. I'm going to have him turn around again. I'm sure he's chomping at the bit here. And what I want you to hone in on as best you can is his shoulder blades. So does he have wing scapula? Now we have yet another view where you see that, let's see, the right shoulder dropped down, left shoulder's higher up. You can also see that head tilt. He's gonna kill me when this is over. Absolutely, it could be tight QLs. So if he has a tight QL, what's gonna happen as this shortens, it's gonna lift his hip up, remember? So when he was turned around the other side, I said that could be a longer leg, or we could have a tight QL. All of these things are possibilities. But can you guys see if he has wing scapula? And I'm gonna jump in there and let you look at mine in a moment. Ginny, it could be weak, anything. Again, he's going to kill me when we're done here, but I've been trying to get him to do more of an exercise routine. He's not a fan. He likes to walk. Eduardo, I don't see wing scapula either. So he is a wonderful subject, wonderfully patient. I think I'm buying dinner tonight. So I'm going to shove him out of the way for a second, and I'm going to let you look. Jeff, I'm going to need you to look at the chat box, so don't go away. I want you guys to look at my scapula. One, because I have a tank top, so it's more visible, and two, I'm a different human being. So can they see it in the, am I centered? Jeff?
Yeah.
Okay. So can you guys see with me? Anybody saying anything?
No.
So you guys have to type it in the chat box. Jeff's monitoring it for me. Can you guys, let's see, I'm trying to get closer and closer.
What are they looking for?
Wing scapula.
Wing scapula.
So look right here, guys.
Right side.
Okay. So
yes, wing scapula, right side.
So
right
see,
wing.
Jeff, if you were to grab that, just take your hand and like pull or push me one way or the other.
Like that?
Well, like if you were to do this. You
mean like
this, you could actually pull me towards you. Obviously, you can only do that if it's in person, right? But so for some people, I guess my point is that some people it's going to be much easier to determine than with others. So you see wing scapula, especially right. Yeah. And so in the case of working with breast cancer patients, we're going to see this quite often because during an axillary node dissection, there can be a damage to the lung thoracic nerve that causes a ceasefire, at least temporary, to the serratus anterior, and that results in wing scap. So when you guys look at your charts and you look up wing scapula, you're going to see, you know, most likely tight weak serratus anterior, tight rhomboids. So what do I need to do? I need to do more serratus specific exercises, something like ceiling punches. And I probably need to do more rhomboid type stretches. So you guys can come up with your own exercises, your yoga, your Pilates, your aquatics, or you can just look in the book under winged scapula and see the pictures of the different exercises that you can do. So we've tried to make this as simple as possible for you. So let me just reiterate here that in person is always going to be better. But even if we do a very simple postural assessment like we're doing today, and we can get some of the basic information. I mean, we know right now from looking at Jeff that he probably shouldn't be doing bench presses and push-ups, that he needs to do a lot of back work, that he needs to do neck stretches, simply things like just bringing his head back into alignment. So when you guys go in your books and you look at forward head, one of the exercises that is in there, let's see if, is simply imagine pushing back, like you see an arrow. I'm simply pushing my head back and relaxing. Pushing back and relaxing. And that is one of the exercises, you know, or just, you know, bringing the head back into alignment, pushing back against a car seat headrest. Personally, I know exactly what Jeff needs to do just from looking at this postural assessment. Yeah, Barbara, doing that in the car as well. I love actually using the car seat headrest to push back against. So you got a little bit of, you know, isometric action there, and you've got the contract, relax, or against a wall, without a doubt. It could be on a foam roller. So I'm gonna let you guys think about, after we're done with this, maybe we'll do a little homework assignment and have you guys put together for bonus homework, or, you know, in case you don't quite hit the mark for your exam, we'll give you extra bonuses for doing Jeff's postural assessment and maybe have some ideas there. All right, hubby has mild wing scaps too. Better, he's not gonna take his shirt off, I can tell you that, Nikki. So that ain't happening. Frank McKenna says, you're earning a big ass drink. Time to play bartender, Andrea. I got it going on. And Frank is like the superstar CETI shirt wearer. And Frank, I just got the navy blue and burgundy shirts in too today. So super stoked. All right, let's get back to business. Now let's do a squat test. So I'm going to move this back a little bit here. And Jeff, come on back over here. Keep in mind that there are going to be clients who you're not going to be able to do all of these things with, particularly when you're working with an older population, or, you know, anybody who's frail. There are certain times that I'm just going to say, you know what, the test is not worth it. But for all intents and purposes, we're going to show you how it's done anyway. So let's get him. I'm going to back this up a bit more so we can get all of him. I'm sorry, I'm scraping up the floor. Okay, we got it all right there. All right, so Jeff, you're going to start with your arms up here. Look straight ahead. Now, before he does this, I want you guys looking at what happens to his arms. Do they fall forward? Do they bow out to the side? Okay. And then I want you, we're going to do different angles. So when we see from the side, we want to see if he collapses forward. We want to see if he gets extremely lordotic. And then we'll look at the ankles and see if there's heel lift. Let me just look and see if you guys have any questions in here first. Nope, we're still on the big ass drink. Okay, let's do it, Jeff. Arms up, nice and slow. Also look at his knees. Does he, you know, do they collapse inward, or do they bow outward? Okay, nice and slow.
Do what?
Just squat slowly. Okay, boom. See how his body falls forward. See how both of his legs are going out to the side. Slowly come up. Okay, again, nice and slow. So does anyone not see that? How his body is falling forward, his arms are coming forward. They're not falling to the side. Let's do one more. Okay, you can sit down for a second while we analyze this.
Go ahead. I'm like it.
Okay, so just looking at that, what do you guys see? So as he's doing a squat, okay, he's falling over here and his knees are going out this way. What does that tell us? And how does that play into our postural assessment? Maria, absolutely going to do sideways too. I just want you to think about this first, okay? So bear with me, believe me. He's going to be like, do I have to do another set? Okay, so he's bowing forward more than physically squatting as opposed to sitting back and down. So Portia, what would you say correctively for, no, absolutely no hip hinge? Chest is collapsed, abduction of the hip and knees, so everything's going outward, guys. Are you saying he needs to lift his chest, or are you saying his chest is lifted, Portia? Tight plantar flexors. You guys are good. Tight hamstrings. Okay, let's watch him again. And now, see, I don't want to cue him too much because I want to see what his body does naturally. So Portia's saying do the same thing. Keep your chest lifted. Okay, slowly sit back into it. So he's still falling forward, Portia. And you can just sit on the bed if you want, Jeff. Much better. Okay. So yes, I'm sure there's limited range of motion in the shoulders. A lot of that is from the tightness in the chest. Now, as much as I love my husband, he would fall in the probably step. He's not sedentary, but he definitely does not have a well-rounded exercise program. And, isn't it always the personal trainer who's gonna kill me? Okay, so needs to posterior tilt pelvis and draw abdominals in. So yes, so Nikki and everybody else, you guys are spot on how to correct his squat. But remember what we're looking at here. We want to see the imperfections, because then our job is to figure out, all right, what do we need to do to correct this? Right now, I don't want to cue him. I simply want to see, what's going on with his movement patterns, with his biomechanics, with his strength, with his weaknesses. Way to go, Sandy. We'll have to talk. She says her husband doesn't work out either, but he walks by the gym every day. Okay. Could definitely be weak glutes merely, and that can go hand in hand with tight glutes, right? I used to think when I went to physical therapy, I had a lot of low back pain, and they said, you have really weak glutes. And I'm like, how can that be? So weak and tight can exist in the same world. So now we're going to go ahead and do these sideways. So I want you guys, to get that different view. And then we'll do one more where I'll have him face backwards, and you can take a look, at his ankles and his Achilles and everything else. So Jeff, again, as Portia says, keep that chest up. So hopefully you can see everything, guys. See him just collapse in at the hips. The arms really aren't dropping. He just has limited range of motion, but he's definitely falling forward. Okay, go ahead and relax. Now, I'm happy to have him do that again if you guys need, but what do you see from that? Or tell me if you need him to do it again, slower. Okay, so knees over toes, absolutely, Jamie, Christine, spot on. Okay, and are you starting to kind of formulate in your heads, Jeff needs to do X, Y, and Z? Could absolutely be a restriction in back, and doesn't all of this tie into his activities of daily living? So it's really important that when we start working with a client to talk about what their lifestyle habits are, what do they spend the majority of their day doing? Yeah, erectors, no doubt. He doesn't have it. You don't have any low back pain, do you? No. So I get all the pain. He just has the forward flexion. All right. So yeah, Ginny, for sure. Let's look at the ankles now and see what we can see. So first, I want you to hone in on the ankles on this side view again. We're going to do that one more time. And then I'm going to have him face backward, and we can look at his Achilles tendons and look to see if his heel is actually coming off the ground while he's doing a squat. Now, the cool thing, once again, when you guys go into, I think it's in module 2, and you look in the assessment information, you can look up forward head, like I said, medially or laterally rotated patella. And then it'll also give you things for the squat test, like arms fall forward during a squat test, or arms go out to the side, or feet come off of the ground. And it's going to tell you which muscles are more than likely tight and which muscles are more than likely weak or weaker. So then you can choose your exercises accordingly. And whether it's Pilates, whether it's yoga, whether it's using weights, whether you're in a pool, You can adapt this to whatever it is that you do. So this course isn't for Pilates instructors. This course isn't for yoga instructors or personal, it's for everybody. Even as a physical therapist, you might change, what you're doing with this particular client when you understand this. And, Jeff doesn't have cancer, hopefully, knock on wood. But we are also dealing with scar tissue and adhesions and fear when we're working with cancer patients, and possibly lymphedema, which can also change posture and decrease or diminish range of motion. Good, Jenny. I'm glad to hear that. Thank you. And we're working on the 13th edition. So my goal is to have it out by October, in which case what will happen in your learning management platform on ceti.teachable, one day you're going to suddenly see all these new videos and new books, and you'll have access to all of that as well. And for those of you who will be recertifying, that's what your exam will be on. Okay, so let's do this. So Jeff, come on back here if you will. Let's do one at the side again, and let's focus on his feet right now, guys. So go ahead, nice and slow. You can look at his knees and his ankles. Let's do one more. So I don't know if you guys are picking up on it, but he is collapsing inward. He is actually pronating when he's doing the squat, which is interesting because when he stands, go ahead and relax for a second. When he is just standing, don't go away because we're going to face that way. When he's just standing there, his feet supinate and his knees are laterally rotated. So very interesting to see how when you're doing a dynamic movement, everything changes. So go ahead and maybe you stand like right here so they can see a little bit closer. Face this way. Perfect. Is that good, you guys? All right, so go ahead and face the back wall. Limited dorsiflexion, absolutely. All right, so let's watch from the back, guys, as he does. Arms up, Jeff. Okay, so his heels are not coming off the ground. And again, I see the tendency of pronation. No, feet are absolutely not aligned. Okay, go ahead and relax, Jeff. All right, so let's give Jeff a break for a second. Let him catch his breath. This is quite the workout. I know when I'm teaching live workshops and I'm demonstrating all of these things, I'm usually exhausted by the end and I have to stop. So, to wipe the sweat off my brow. So we'll give him a break. Yeah, Marilee, weight bearing more on the left. And a lot of this probably has to do with that unlevel iliac crest, possibly tight QL, possibly leg length discrepancy. But even if I could take a tape measure and go from the ASIS to the medial malleolus, I can't do that virtually. And most people will tell you that you have to have an x-ray to really determine if somebody has a leg length discrepancy. So yeah, absolutely, Eduardo. And like I said, we're not going to have time to completely do an exercise program for him. So what I want you to do is just take all of this information, one, understand how to do this to your clients virtually, and then we can all kind of work together to put together an exercise program for him, which I'm sure he'll love. Okay, so could Jeff's left foot pronation be causing left knee valgus and compressing weight? Absolutely. Because the kinetic chain, everything's together, right? If you take that little skeleton that's hanging in the science lab, you don't have the arm over here and the leg over here. Everything's connected. So if we jiggle that thing, everything on it is going to shake. And the same thing is happening with us every single day of our lives. All right, Abby, thanks for being here. We'll see you. Let's see. Okay, so we still have 15 minutes. Feet are solid, but his bow legging may have to do with actual bone structure from childhood. That could absolutely be the case. And Jeff, do you have any bone malformations or anything? So he is saying no, but of course, I think, many of us probably don't even know what was done during childhood. So the best we can do is manipulate stretches and strengthening with our clients, unless you're a physical therapist or an occupational therapist. No, he has not, Vanya. Of course, that may be in the future if it's not corrected, right? Because if somebody continues, it's like a car. If you have, you have 4 wheels and they're supposed to be going like this, but what if they're going like this? So when there is improper traction or tracking, excuse me, you're getting more wear and tear on the joint than there should be. And eventually it's going to blow. Somebody's going to end up, you know, blowing their ACL or having to have a knee replacement. So no, he has not had any surgery. All right. Now, doing a modified Thomas test is quite interesting when you're doing it virtually. But we are going to use the bed. And from there, we'll also do the goniometric measurements. And just to show you guys, in person, I use my 12-inch. So we've got mommy and daddy, or daddy and baby goniometer. I use the 12-inch one in person. But this little bugger, this little 6-inch one, is awesome for literally going right up to your computer screen and doing the measurement. So, you know, you can line it up while your client is there lying on their bed. Will it be as perfect as in person? We've done a pretty good job when we're doing our virtual training, universities and everything, and we've been doing the goniometry. When the people are on the other side of the computer and they're taking the measurements, they're getting the same thing as I'm getting doing it in person. So I'm really pretty convinced that we can do a good job with this. So Jeff, we're going to go ahead and guys, I'm going to hold this while Jeff moves my tabletop so I don't scratch up the floor. Hold on for just a second. Yeah. Okay. So any questions so far, guys? This is your time to ask away. All right, so we're gonna go like this. Okay, so for a modified Thomas test, now in real life, if we could use an exercise bench or better yet, a massage table, that will be better. The bed's a little bit soft and obviously they've got to have something to prop their computer up and there's a lot of little mechanical issues, but it's still going to pretty much show us what we need to see. So I'm going to have him do it sideways and then I'm going to have him do it straight on. So we can look to see if he has tight quads, tight hip flexors, or, you know, tight lateral abductor muscles, tight IT band. Merely a dining room table could absolutely work. Maybe not ours because I'm not sure that it wouldn't fall apart. Our bed is probably a safer bet. But you also have to think about what the person on the other end is going to be comfortable doing, especially if you're working with seniors or somebody who's just come out of surgery. So let's say, for example, we're working with somebody who's had abdominal surgery. They've had a hysterectomy. They've had a retropubic prostatectomy. They've had abdominal tram reconstruction. We want to make sure, even with these assessment protocol, particularly what I'm going to show you now, that they're a good 12 weeks out, that they're completely healed before we put any undue stress on that incision, because there can still be internal healing going on. And keep in mind, if they've had an abdominal tram, they don't have their rectus abdominis muscle, okay? They're not going to be able to roll back. So we are going to have them go sideways. And it may not be pretty, as you can see, okay? But they're gonna have to do whatever they need to get into that position safely. So is it perfect? No, but it's still very good. So what I'm going to instruct Jeff to do is to sit on the very edge of this bed, and I'm going to give him a demonstration. So maybe you're able to give your client a demonstration, maybe not, that's okay, but you'll describe the best you can. So he's almost to the point where he's falling off the bed. And I would be saying the same thing if somebody was on a massage table. I want them to be right on the edge, and then they're going to roll back. We want to make sure your client doesn't roll off their bed. So let's come a little inward. And then I'll have him bring both legs in, and then he can hold the one leg in. Now, one thing I can tell you is because of Jeff's forward head, he's going to have a pillow underneath his head. And so then I'm going to have him pull his knee in as close as possible. Now, before you start analyzing me, because I know, think about things like if somebody's got a big belly, they're going to have a tough time bringing their knee in. Think about, you know, how they're going to get onto the bed, making sure they don't fall off the bed or the kitchen table. In some cases, maybe they happen to have a massage table, but these are all factors, and you guys will weigh whether or not the results are worth putting your client at risk, depending on that client. So maybe if it is somebody who's elderly or frail or, you know, recovering from surgery, maybe you ask them to have their spouse or their child or their friend or their partner or whoever there to help spot them and just make sure that they don't get injured. Which brings me to another point, and that is when you are doing virtual training, I like to make sure I have, well, I should say, if I were training, I would do this because I'm not training individuals anymore, but I recommend that you guys get an emergency contact and the local way to reach 911 in that state or country or whatever. Because if I call 911 while I'm training Frank in Virginia, I'm going to call 911 in Portland. That's not going to help Frank any. Okay, so I need to know how to reach emergency support in Virginia Beach if something happens with Frank. And that is something I don't think people are really thinking about when they're working with somebody. You need to have a plan. So if something happens, your client passes out, what do? You're on the other side of the computer. Okay, so let's do this, Jeff. So I'm out of the picture and I am you. I'm going to say, Jeff, go ahead and move over a little so you're not right at the corner of the bed. Now, very carefully, I want you to roll back, keep your belly engaged, pull your belly button to your spine. Awesome, bring those knees in. Okay, now before you let your leg go, Jeff, try and relax your head, your chest, and just take a deep breath. Now place both hands behind your right knee and pull it in as closely as you can to your chest while you let that left leg go. Can you bring your right knee in any more, Jeff? There you go. Okay, guys, not perfect, but can you look at his hip flexors? And I can move this closer. Okay. Now, unfortunately, what happens is because the bed's squishy, when he does this, he's just kind of sinking into the bed. All right. Yeah, good job. Okay, so Eduardo, you see that because this is not lined up straight up and down. Let's do this, okay? And we've got the sun shining in here now. Because it's out slightly, that is indicative of slightly tight quadriceps. If it were like this, it would be super tight quadriceps. Okay, knee flexion not at 90 degrees, exactly. Now, if we pull him in a little bit more, which of course, if I'm on the other side of the computer, I can't do. Yeah, I would say he probably has a little bit of tight hip flexors because he's sinking into the bed. It's kind of hard to tell. In either case, it's definitely not severe. But because he sits at a desk all day long, very common to have tight hip flexors. All right, so now I'm going to have him do the other leg. And I think the best thing to do is going to be to go to the other side, which look at him. He's already on top of it. Okay, so I'm just, can you guys all see that okay? So we've got the other side of the bed. Okay, knee flexion not at 90 degrees. Good husband, says Beth, or no, somebody said good husband, but it went away. Merrily, yes. All right, here we go. So now I always tell you to put your hands under your knee so you don't put any pressure on the knee. All right, let's see. Can you guys see okay? How's that? There we go. All right, I think that's an even better view. So bring that knee in, Jeff. Good. What do we see here, guys? Yeah, for sure. And I think this quad might be a little bit tighter than the other one. And in either case, so Jim, you see, yeah, tighter than the other one. You guys are typing faster than I can read. So I think it's safe to say that both sides, he's got tight quads and maybe a little bit of tight hip flexors. So we should be telling ourselves now, okay, this guy's got to be stretching his quads. He's got to be stretching his hip flexors. And we also know that this is somebody, go ahead and come up nice and easy, Jeff. And then we're going to do it from the front. This is somebody who isn't real keen on structured exercise. And so when I'm thinking about putting together an exercise program for him, I'm like, okay, how can I meet him where he's at? He just went to the other room. And I have to do something that's going to be motivating enough, you know, that yes, Marilee, make it fun. So, okay, if Jeff doesn't want to, you know, go to the gym or go downstairs to the gym, maybe when we're going on our walks, you know, I'm going to stop and stretch with him to do quad stretches. You know, I always work with him on his posture when we're walking, but unfortunately we haven't been able to do it as regularly as possible, just life. It is absolutely hard to have your spouse or partner be your client. And the other thing is, you know, even workout partners, you know, sometimes it can be super motivating for a couple to work out together. And other times they're like, I don't want to work out with her, or I don't want to work out with him. So these are all possibilities, guys. And as we get to know our client and what their likes or dislikes are, we can work better to meet them where they're at. And, you know, I talk about this, like if you have a guy who was, you know, I use the term weekend warrior, you know, he goes on the weekends and he plays basketball and football with his buddies and for 3 or 4 hours, but then they finish off with pizza and beer. Okay. This guy does not want to do yoga. This guy does not want to probably even go do a structured exercise program. But if we know he has limited range of motion, you know, think about basketball and think about basketball skills and how you can turn that into at least a starting point to an effective exercise program. And, you know, throw in the stretches, throw in dynamic movement. I was watching Dan Ritchie and I are doing a program together, and he, you know, of course he focuses on functional aging. And it was interesting because he was talking about how working with older people, mostly he's talking about baby boomers, but whatever, it could be any time in your life when you're working with cancer patients, is having them do squats and lunges in wide stance, narrow stance, diagonal, because in real life, we don't plan our squats when we do them. We don't sit there, you know, okay, I'm going to go to the bathroom now. Let me make sure my legs are lined up properly. And okay, cool. I'm sitting down. No, I mean, you go to the bathroom, you're plunking down, you're doing whatever comes to you naturally. So we have to retrain people and train them in different planes of motion. We can't just work in the transverse plane. We can't just work in the sagittal plane. We've got to look at all of the above. Okay, let's see what you guys are saying. Nikki, I'm seeing compensation for movement of hip flexion all the way up the length of the spine as his neck tilts back and chin lifts up slightly. Amen. Amen. And, you know, that is something I see when I was working with people more regularly. You know, I would have people lying back and their heads like this, which of course is restricting their breathing as well. So they're not getting that oxygenated blood to their muscles. There are so many problems with this. It goes way beyond just how you look, or even structurally. It can affect everything. Let's see. Get a beach ball and toss it with him. All planes, reactive, all muscles, and play music. All right, Jeff, you got that? He's going, no. Keep those suggestions coming. All right, guys, let's look at him from the front now. So, I know, we're good. So right on the edge, and we're going to do the same thing. And so now what I want you to look for is if his leg goes out to the side. Ready? So keep one knee in. He's got my hairs hanging off the bottom of his socks. Okay, yeah, there you go. All right, what do we see, guys? Look at the patella. Look at his femur. Keep pulling that knee in there. He may never talk to me again. Okay. Yeah, a little bit. Not horrible. And again, like you may be seeing it from a different angle, but you know, I can see that it's going out. I can see the patella more lateral. Okay, I'm gonna have him switch it up, you guys, real quick. Okay, now on this side, I also see the tightness in the hip flexors, even more so. Do you guys see that? Yes, external rotation, lateral rotation. So I would say this side, he's got that tight IT band, maybe tight piriformis. But more than anything, more than, you know, diagnosing my husband, so to speak. Go ahead and relax, honey. Come on up. But we're not done with you yet, so stay there. He wants to run away. So more than anything, Oh yeah, I'll have him do it again, Barbara. More than anything, I want you guys just to understand conceptually how to do this. So, we can do another webinar and do exercise programming by all means, but for now, I want you to just get a feel for how you can do this virtually, in the comfort of someone else's home. So real quick, Jeff, can you do this one more time so they can see your feet? And Ginny says, don't try and do everything all at once. You're a great sport. Thanks, Ginny. Okay, is that better, you guys? How's that? Okay, so oftentimes we see the lateral rotation here, but also we may see them go into more of a supinated foot. Is that what you were looking for? All right, I know there's a little bit of delay when you guys are writing. So we are at the hour, but I'm gonna finish off with the goniometers. So if you guys have to go, this is gonna be recorded and I'll send you the recording, so don't stress out. But I don't wanna cut you short. So let me show you how to do the goniometers. And if you have a goniometer, you can follow along from your computer screen and see if you get the same measurements as I do. Now, if you have a small computer and a big goniometer, that's going to be a problem. So you can order these on Amazon. This one is Baseline. This one is Healthy You. But don't buy the cheapest one possible because usually they're very flimsy and you'll end up just replacing it. You're probably going to pay on average about $10 and there's plenty of them on Amazon. Okay. Nikki, side tighter but less later knee deviation and external rotation through the hip. So I don't know if any of you guys are making notes. Obviously I'm not, but if anybody has jotted all this down, if you want to shoot me an email at andrea@thecancerspecialist.com, I will then put it up in the Cancer Exercise Specialist Facebook group, and we can all kind of do a little case study on Jeff, which is always good practice. And keep in mind, when you're working with cancer patients, we're also adding all the side effects of treatment. So, the assessment is only a part of it. Okay, so let's go ahead and have you lie sideways, get yourself somewhat comfortable with the pillow. So go ahead and this way. Now, when I have...
You're talking about back?
Yeah, on your back. I always tell somebody to keep their knees bent. No, you're gonna, here, scoot down a little more. You're gonna put your feet on the bed. So you're like firmly laying on the bed.
Oh.
Okay, and keep in mind, your clients aren't gonna know what the heck you're talking about any more than Jeff knows what I'm talking about. So that's where we have to describe it to them. So I want him to lie on his back. If I tell him to lie supine, they don't know what supine is. So lie on your back, place a pillow under your head, or not. If he's laying back or your client's laying back and their head's tilted up, then you just instruct them to put a pillow underneath their head so that they're level. I always want their knees bent and their feet flat on the bed, on the massage table, on the floor, wherever you're doing this. Okay. If you have a reason that you think this person should not be doing this measurement, then don't do it. It's not the end of the world. Usually what I do is before I even take goniometric measurements, I will have them stand and go through all of the planes of motion, do external, internal rotation and extension. And I will look to see if there's a difference between each side. Or if they appear to have really limited range of motion, because otherwise I don't need to put them through this. If it looks like they've got pretty good range of motion or they're equal, more often than not, you're going to be doing this to anyone who's had breast cancer, surgery, reconstruction, radiation to the chest area. Doesn't have to be just breast cancer. It could be lymphoma, it could be lung cancer, or if they've had head or neck cancer and or radiation there. Those are usually the things cancer related that will limit range of motion. So while I show you in the book how to take lower extremity measurements, honestly, there are very few times that I can remember doing that, unless there was a sports specific reason or somebody was recovering from knee surgery or something like that. Usually it's going to be upper body, and that's the most functional, as far as day-to-day activities and so on and so forth. All right, so what I am going to do is I'm going to show you how to do it if you were there. What you're going to do from where you're at is imagine taking these measurements on your computer screen, okay? So in flexion, which is going straight up like this, the axis of rotation is basically, what I tell people is have them bring their arm out and find that little indentation, okay? And of course, if I'm there in person, that's what I'm feeling for. And I am going to try and stay out of your way here. I want his palm, let me come in a little bit. Okay, how's that? Palm should be facing the body, thumb up. Okay, I'm gonna find that spot. I also want to move this pillow out of the way. Scooch over a little bit. No, just let me get this, because otherwise it's gonna be in the way of his arm. So you guys would be holding this up to your computer, and I'm gonna tell Jeff, because I'm not gonna be here to push his arm in, I'm gonna say keep your arm as close as you can to your body and imagine 2 panes of glass as you're going up and over, and try not to let your arm go out of those. Can you guys can't hear me, Barb? Is it because I went away from the computer maybe? Okay, cool. All right, so here we go. So my stationary arm, which is the one that's attached to the circle, is always going to be parallel. In this case, parallel with the bed, could be the floor, it could be the massage table. While the movement arm is going to move with his arm, okay? So whenever you're ready, Jeff, nice and slow, straight arm. So no bend in the elbow. Okay, I'm just gonna move this for a second. And again, bed is not great, especially because we have one of those Tempur-Pedic ones. What you wanna see, you're going all the way up, all the way up, all the way up overhead. Okay, here's what you're looking for. You don't wanna see any excessive scapular motion or arching in the back. Now, he's stopping himself there, which is probably his body saying, okay, this is enough. So I want you guys to, if you have a goniometer, you can take that goniometer, stationary arm remains parallel with the bed here, and I take the movement arm and I go to the middle of his arm at the elbow, okay? Because if I go to one side or the other, it's gonna change the measurement a bit. All right, now I don't know if anybody is playing along with this, and you're not in trouble if you're not. But so go ahead and relax. I always have my client relax their arm as soon as I take the measurement, because it probably is uncomfortable, especially after they've had surgery. Now, what you're looking at is right here, okay? There are 3 sets of numbers here. We're doing the 0 to 180. So I have to see what this says because I can barely see. So he is at 152. So you're probably seeing it backwards here. Now, if you look in your book, norms for flexion are 150 to 180. So he's at the lower end of normal. But in the absence of trauma, or if both sides are 150, that's probably his norm. That doesn't mean that we can't do exercises to improve it. And you can start to think of, well, what exercises take place in flexion? Well, I gave you the example of Warrior One. It could be a forward wall walk. It could be just sliding on his computer desk to get more flexion. There are examples in your book for that as well, okay? But nonetheless, if he didn't ever do any better, he is at the point where he can do resistance training, because he has to be at least 90% of the low end of norms. So if our norms are 150 to 180, anywhere from 135 up, I can now, if I wanted to, go ahead, raise both arms up for me. If I wanted to give him a weighted bar or a dowel and have him do pullovers with resistance, or cables, or Pilates, go ahead and relax. A Pilates reformer or anything, it's okay. He has enough range of motion that we can move into strength training, okay? But if he was less than 135, then I'm gonna just focus on range of motion exercises until he's at least at 135 before I start adding resistance. Does everyone understand that? Because that is a key concept. If you don't want to write it on the screen, perfectly fine. Reach out to me, happy to explain it in more detail. Flexibility, range of motion trumps everything else. And just because they're limited in one plane of motion does not mean they can't do resistance training in other planes. So maybe he's good in flexion, but maybe he's limited on external rotation. So I might be just focusing on range of motion or stretching exercises for external rotation, but giving him resistance for flexion. And then all in all, Okay, cool. Vanya got 154. So see, we're not too far off. We're only 2 degrees apart, and that could just be user error on either of our part. So this really works great virtually. The hardest thing is going to be abduction. So some of these, they may not be able to do supine, and you want to make sure that when you notate your results, so in the back of the book, you have the assessment sheet, and it has, you know, flexion, extension, left, right. If you're doing any of these measurements in an upright position, good job, Kelly, awesome. Make sure, good job, Jamie. I know, it's kind of crazy that it actually works. But if they're doing it upright, make sure that you notate that you took that measurement upright. Because if the day ever comes that a physical therapist or even you take the measurement in person, it's going to be different because you're working against gravity versus having gravity on your side, okay? All right, so that being said, while I have him in this position, what's this, breast cancer patient lymph nodes removed, causing limited, absolutely. So any of these surgeries can cause limited range of motion. And then what if they have swelling from lymphedema, right? So I'm gonna have him scooch over a little more now. So I just want his elbow right here. Everybody see that okay? Let's jump on in there. Okay, so in external or internal rotation, the axis of rotation is the elbow. Now, if you're doing this on the floor or your client's on the floor, then obviously it's going to be a little bit different because I can't put the axis of rotation exactly at his elbow. So also make a note of that because it might change at 10 degrees. It's okay as long as you do the same thing consistently every time. So the stationary arm and movement arm are all starting here, same position that the arm's in. Now, because I'm going to do internal rotation first, I'll just kind of move that out of the way a little bit, getting it ready. In real life, guys, I would have my hand gently on his shoulder, feeling for excessive contraction when he involves his muscles to, you know, go further into internal rotation, which, you know, we all compete with ourselves, and even your 80-year-old client's going to try and impress you and themselves by having better range of motion or whatever. So we want to make sure that they're not compensating with the rest of their body in order to achieve, you know, a different measurement. So palm is facing forward. You're going to take your goniometer, guys, and hold it right there, axis of rotation, and follow along. So very slowly, Jeff, go ahead and kind of taking your hand to the bed, but slowly. And I'm going to instruct Jeff that if he feels it start to contract here, that he should back off a little. So do you feel like you're using your muscles to bring your arm forward there? Okay, so he just backed off a teeny bit. Guys, I'm coming back here with my axis of rotation. I am taking my movement arm to the epiphyses of his wrist, okay? Now I have 52 degrees. I guess that's his magic number. No, it was 152. Okay, so tell me what you guys got. Were you able to do that? Barb, good question about the warm-up. Actually, we don't want a warm-up because we want to see their true range of motion. This is not going to injure them as long as they're not being excessively forceful. Okay, Maria, good. We're on the same page. So we don't want them doing like an exercise program without warming up, but this we want them to be doing just cold turkey. Okay, cool, Beth. So again, we're not too far apart there. 52, 54, 56. Okay, good job. Now I would of course have him switch around and do it on the other side as well, but I think hopefully you guys get this. So now I'm going to switch sides so I'm not in your way here. I'm going to go back here. Okay. Now, if even without a goniometer, like if he's laying on the floor and he goes donk and his arm is laying on the floor, then I know it's 90 degrees. I don't even need to break out my goniometer. But for argument's sake, always make sure the movement arm is on the outside. Otherwise, you're going to end up reading this backwards and be all confused. So go ahead, Jeff. And I want his chin always up, his feet always flat, belly, you know, drawn, belly button drawn to his spine. So he's got good neutral posture. Okay, whenever you're ready. Backwards, 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 backwards. Okay, so I've got my axis of rotation. My movement arm, once again, is going to the epiphyses of his wrist. And I want to make sure that this stays straight up and down. So sometimes we have to fiddle around with it a little bit. Now, guys, I have about 77 degrees. Yes, thank you for bringing that up, Barb. So kind of hard to tell from where you're at, but I always want a 90-degree angle right here. Sometimes people's arm will go in, sometimes their arm will go out. A lot of that can just depend on their own body mechanics. Sometimes it could be if they're a bigger person, that could be muscular or body fat, okay? But 90 degrees right here. So awesome. So Beth, we're getting similar measurements. You know, it may be off by a couple degrees, but hopefully you guys are seeing how effective this can be, even through a computer screen. So I don't think any of us want to do it this way forever, although I am getting kind of fond of being home. But this is a good option. So now for extension and abduction, I'm going to have him upright because these are both measurements that I normally do, you know, being above him. So just to give you an idea, just so you know how to do this, with abduction, palm is up, the axis of rotation is at the armpit, and then as they move their arm, there are a couple things I'm looking for. One is that they're not rolling it, okay? So when you see the palm turn. Two is that they're not coming off of the floor, the bed, whatever. So if that were the end range of motion, then I would take that measurement there. And this is not accurate, guys. I'm just giving you an idea of how this is done. So the axis of rotation is right at the armpit, and you're kind of hovering over this person to get that measurement. And then to do extension, go ahead and roll on your side, if you will, Jeff. Scooch back a little closer to me. Once again, you cannot do it this way virtually, but I just want you to see how it would be done in person. Robin, you're asking, what would a frozen shoulder look like? Very limited range of motion. You know, more often than not with abduction, they're not going to get above here, and with flexion, they're not going to get above there. And that's why I do this eyeball before I even get started, because if they can't even get parallel to the floor, they probably need to go to a physical therapist. I will not diagnose a frozen shoulder. I'll just say, you know what, I think that you would be well served to ask your doctor to give you a prescription for physical therapy for a little while. You and I will continue to work on your low body. We'll help you to, you know, strengthen your heart and your lungs. We'll help you to lose body fat, improve lean muscle mass, all these other things, but they can help you more specifically with regaining range of motion in that joint. Okay, so with extension, if I were in person, I would have him bring his knees like in a fetal position, okay, and then have his arm like this. The axis of rotation is going to be the same as flexion, only now he's bringing his arm back here, okay, and I'm making sure he's not rolling over like that. And then I take my measurement. So I go to the epicondyle of his wrist, and the stationary arm is in line with his body. Like I said, you cannot do this virtually. So Jeff, let's have you stand up, and we're going to finish off with these last two. I almost lost the computer there. That would not have been good. Okay, guys, so play along with me here. So come up a little bit more. Okay, we're going to instruct our client to stand up nice and straight and bring their, wait for me. He's like, please let me out of here. Bring their arm up, thumb leading, but we don't want, as soon as you see this, you have them go back. And so maybe you ask them to wear a tank top or something. So I'm going to instruct him to bring his arm up as high as he can. Okay. So I want you guys to focus on this right here. And look what happens. This is his cheek. Nice and slow, Jeff. Okay, do you see how he goes inward? So he's crossing between abduction and flexion, because that's the point where he starts to compensate. So in real life, I can be like, You're going to have to really watch this on your computer and say, okay, stop. So have him hold that there. I go to the axis of rotation. I make sure my movement arm's on the outside. Axis of rotation, stationary arm is in line with the body, and then zoop, right there. Anybody want to try and take that measurement with me? So right here. Hold that there just for a couple more seconds, Jeff. All right, let's see what we all got. Go ahead and relax. We just have one more and then you can go. So I got just over 110, maybe 111, 112. Norm is 150 to 180, just like flexion. So unless he has at least 135 degrees, he should not be doing anything with resistance. Not that he would, right? But what is the best way? Now think about it. If he has tight pecs and tight lats, think about how that's inhibiting abduction, right? So I think stretching is going to cure a lot of this. And for many people who have upper cross syndrome, this is what you're going to see. The average yoga instructor, their range of motion is awesome. The average personal trainer, probably not so good, because we end up doing more weights and not enough stretching. As for Pilates, I don't know. Maybe you guys are as good as the yoga instructors, probably. Okay, Ginny, awesome. Foam rolling. Can we foam roll on a client who has had lymph nodes removed? Can we foam roll on Jeff? Hell yeah. Breast cancer, lymph nodes removed? No. Never apply pressure like that on an area where lymph nodes have been removed or irradiated, as that will reduce the flow of lymphatic fluid and can increase swelling or actually stir up and cause or lead to lymphedema. So did anybody else try and take the measurement, just out of curiosity, if you were able to get the same thing? All right, Nikki, thanks for being here. One more thing to go, so you can go back to the video replay. Jeff, if you'll just stand sideways, we'll finish you up real quick. Axis of rotation, you guys, on your computer screen, you're putting it right there, okay? And what you're looking for is he's bringing his arm back. Tell him to keep it as close to his side as possible. Make sure he is not activating his traps. So right there, relax, go back down a little bit. And I can see that. I don't know if you guys can see that. Okay, keep your arm close to your body. Now go ahead, stop. Axis of rotation, movement arm. And I have about 32 degrees. You're done, you can go. Thank you, Jeff. He's like, oh my God, thank God. So I got about 32 degrees. Norm for extension is 40 to 60. So what is 90% of 40? We're just shy of him being able to do, let's say, a straight arm press down or tricep kickbacks or dips. Because until he has that range of motion, all we're doing is strengthening him in that limited plane of motion. So I'm really happy to see, I know not all of you have the little goniometers to be able to do this, but for those of you who have, we're getting the same measurements. Yeah, so Jamie, try and get a hold of a little baby one. They're so cute. I love doing the little goniometer family. I'm gonna get such a rash from putting him through this. It was a last minute thing because I was gonna have somebody do it virtually, but I personally couldn't figure out how to make them be on the screen and not me. So Tracy, hit me up. Would love to touch base while I'm in Portland. Thank you all for being here. It'll take about an hour to do the replay. Not that you're like, oh, I wanna watch the replay, but it'll be there for you. You can use it to look back on. And I hope this was helpful. I hope this will help you in transitioning into this COVID world of ours, and have a spectacular weekend. I am heading to California on Sunday, and I'm going to try and at least disappear off the face of the earth for 2 days. So thanks again, guys. Have an awesome weekend.